our research event today. As you all are signing on, Bethany has just put something in the chat asking you to click on a menti.com link to tell us where you're calling in from. So please go ahead and do that. I am looking forward to today's session. If we go to the next slide. So this Global Surgery Research Seminar hosted by PGSSC is a seminar of 8 sessions that explores a host of different methods and outcomes within the global surgery space, global surgery research. Each session is 2 speakers that use either similar methods or cover similar topics. They'll present their research, they'll present their papers, and then we'll have an open discussion of those papers, the methods in those papers, the results, the implications. This is all recorded and the videos will be posted after the seminar. Could you go to the next slide? Just real briefly, the hosts of these seminars or the faculty leads at the program in Global Surgery and Social Change are Adeline Boatin and Bethany Het-Gauthier. And the fellows and RAs that are involved are here at the bottom. Next slide. So let me start by introducing our first speaker, who is Dr. Andy Healey. Dr. Healey is a senior health economist based at King's Health Economics and the Center for Implementation Science at King's College in London. His main area of work is in health and social care evaluation applied to the UK National Health Service, especially within a global health context. Dr. Healey has over 25 years of experience as an economist, working across the academic sector, has had previous posts at the University of Aberdeen and the London School of Economics. He's also an economic advisor within the central government, the UK Home Office, and the Ministry of Justice. And our second speaker after Dr. Healey will be Dr. Melanie Sion. Dr. Sion is an assistant professor of surgery at Yale University in the Division of General Surgery, Trauma, Surgical Critical Care. She has a long-standing commitment throughout training and now as a faculty member to developing surgery and surgical services in low and middle income countries. She is the lead in global surgery at Yale. Her primary collaboration and area of work is in Malawi and with Malawian general surgeons. She also collaborates with Women in Surgery Africa, a subgroup of COSEXA, the College of Surgeons of East, Central, and Southern Africa. She has diverse areas of interest, including operating room efficiency, minimally invasive surgical approaches. She hopes to improve the conduct of trauma registries throughout the COSEXA region of Africa. With that, I will turn it over to Dr. Healey first.
Thank you for the introduction. I hope you can all hear me. And I hope you can all see the slide.
We can, yes.
Is it in presentation mode?
It is not yet in presentation mode. Now it is. Great.
Thank you very much. Thank you very much for the introductions, and good morning or good afternoon from London in the UK. This is the paper I'm going to be discussing, a paper that I co-authored with some clinical colleagues in Norway, and it concerns a cost effectiveness analysis of the WHO surgical safety checklist that was carried out using data from a clinical trial that was undertaken in Norway. The paper was published a couple of years ago. Just to give you an overview of what I'm going to present, I'll just go into some background. Much of that material you'll probably be familiar with, so apologies if you are, and I'm telling you about things you already know about. I'll talk a little bit about the project funding and how the collaboration came about and the timelines to the project, a little bit about the ethics. The guys who organised or invited me to speak at this wanted me to say something about the ethics and the project funding. Although I should stress that I didn't get involved with this work until quite a late stage. So I wasn't actually involved in the certainly in the ethical application process, ethics applications process. I then talk a little bit about methods, data, and I'll talk about some of the key findings in the paper. I won't talk about all the findings because there won't be, or all aspects of the paper, because there won't be enough time to do that, but maybe we can cover that in some of the questions afterwards. And then I'll say a little bit about what some of the main challenges were and what perhaps some of the lessons learned are from the work that were carried out. So yeah, back in 2008, the World Health Organization published a series of guidelines around promoting safety in surgical intervention. Obviously, surgery carries enormous benefit for patients, but I think the guidelines were published in response to a concern about the existence of avoidable perioperative deaths and post-operative major complications in surgery. And so following that, the Safe Surgery Saves Lives study group, who I think this group, it was a global group, and I think it may have been led from clinical people at Harvard, actually. Forgive me if I'm wrong about that, but they devised this 19-item checklist aimed at promoting safe surgical practice. And following that, there was a paper published in the New England Journal of Medicine in 2009 that presented some data based on a cross-country observational study design that suggested that the application of the checklist was effective in preventing perioperative mortality and in reducing the incidence of major complications post-surgery. And then I think in response to that, some clinicians in Norway decided that they wanted to take it a step further and to test out the effectiveness of the checklist using a gold standard research design, a randomized control trial of the checklist. And the findings from that were published in Annals of Surgery in 2015, and they essentially backed up the findings reported in the earlier paper in New England Journal of Medicine. And so what happened is that the clinical lead on the trial carried out in Norway did a postdoctoral research secondment over in London at King's College, and he met up with myself and with some other colleagues, and we discussed, well, why not try and do some more work around the economics of the checklist using data from the clinical trial that they'd undertaken in Norway. And so this became a collaboration between ourselves at KCL and our colleagues in Bergen. And we started work on this, I think, in around 2017. Just saying a little bit about the ethics approval process. We didn't actually need to get ethical approval for the cost effectiveness analysis itself, because we were using data that had already been generated by the clinical trial. Now, obviously, the people who led the clinical trial did apply for ethics approval in Norway, but it was deemed by the ethics board over in Norway that, in fact, what they were undertaking was a quality improvement project and not a research project. So it was deemed that ethical approval actually wasn't required, which in one way was a good thing, I think, for the clinical team in Norway, because it meant they didn't have to go through all the process of applying for ethics approval. But it did lead to some complications for them when they came to publishing their findings, because they couldn't, initially at least, register the clinical trial and get a trial registration number. So that kind of led to some complications on that side of things. In terms of the project team, the clinical trial itself was led by a team of senior clinicians over in Norway, headed by a senior I can never say this word, a senior anesthesiologist, an infection specialist, and a consultant surgeon. And they were supported by a statistician and a theatre nurse who was responsible for data collection. When we got to do the cost effectiveness analysis, the team basically consisted of myself. I obviously liaised a lot with the clinical lead, Dr. Arvid Steiner Haugen over in Norway, because he had access to the data from the clinical trial. And we also had a senior colleague here at King's, who was an expert in patient safety and in implementation science, who was involved in the project as well. And in terms of funding, the clinical trial received finance from the Western Norway Regional Health Authority Research Fund. I can't give you details about how much funding they received for the clinical trial, but that's where the funding came from. We didn't actually get a specific grant to undertake the cost effectiveness analysis, but my time on the project was funded through an infrastructure grant that funds part of my salary, that comes from the National Institute for Health and Care Research, which is basically the research arm of the National Health Service in the UK. And they fund something called the Applied Research Collaborative for South London. That's basically an organisation that promotes applied research with the local National Health Service in South London, particularly around improvement and translation of evidence into practice. So that's some project funding and some background. So now let's move on to some of the methodological details of the project. So economic evaluation is broadly defined as the comparative analysis of alternative courses of action in terms of both their resource consequence and in terms of outcomes or effect. So economic evaluation, it's a form of decision analysis, and it aims to support or to promote decision-making that is consistent with the goal of increasing total patient benefit from limited resources. And it's important to stress, I think, that cost effectiveness analysis is only one type of economic evaluation. There are other forms of economic evaluation, such as cost utility analysis, which you may have heard of, and cost benefit analysis. There are obviously similarities across all these different types of economic evaluation, but main differences concern how they approach the measurement of outcome, patient outcome, and also in terms of how they intend to inform decisions as well. Specifically, cost effectiveness analysis aims at jointly evaluating the resource or the cost impacts of a healthcare intervention, combined with measures of patient outcome that might typically be expressed in terms of, for example, symptomology, scales of symptom severity, in terms of behavioural effects, or in terms of impact on incidence of types of clinical events, such as in the case of this study, surgical complications, for example. So why undertake? What was the rationale for undertaking a cost effectiveness analysis of the checklist? Well, at the point at which we started thinking about this work, there wasn't any economic, or there hadn't been a full economic evaluation of the checklist linked to a data generated from a robust research design. And that's an important gap, because economic data and economic evidence has become increasingly important within licensing approval processes and in terms of the development of clinical guidelines, and also in terms of business case development as well, where there may be work around aiming to gain state funding or funding from non-government organisations that would fund scale up of important clinical activities, for example, in low-income country settings. Right. So I just want to say a little bit now about the study setting where the clinical trial was carried out, and within the and what types of surgical specialties that the clinical trial was undertaken. So the checklist was actually rolled out across 2 hospitals in Bergen, in Western Norway, but in a teaching hospital and in a central community hospital. But because we could only access data from the teaching hospital, that meant we could only carry out the economic evaluation, the cost effectiveness analysis, using data from one of the hospitals. And that also had implications for the number of surgical specialties that we could include in the economic evaluation as well. So the actual checklist was rolled out across 5 surgical specialties that you can see there on the slide. But because we could only use data from one of the hospitals, the cost effectiveness analysis was limited to data from only 3 of the surgical specialties that I've highlighted on the slide, which covered just over 3,700 patient admissions over the period of the trial that ran roughly from, I think it was, from August 2009 through to June 2010. So I think that's, it was roughly a 10 or 11 month period. So the primary study questions for the cost effectiveness analysis were, firstly, given that there was good evidence that the checklist was effective in reducing perioperative mortality and reducing the incidence of major complications, the next question is whether these clinical benefits would be achieved at greater or reduced cost to the hospital care system compared to usual practice in the absence of the checklist. And secondly, given that the data that we used from the clinical trial are effectively sampled from a population, we needed to make some kind of assessment as to how confident or certain we could be in our conclusions regarding the cost effectiveness of the checklist. So we did have some priors, if you like, regarding what we expected to be the direction of impact in terms of the resource consequences of the checklist. So obviously, we would expect that some costs would have been generated in actually implementing and embedding the checklist into the existing clinical care pathway. And these implementation costs, the type of things that I'm thinking about, were detailed in the paper, but they cover things like expenditures on the checklist manual, on e-learning facilities, on the cost of clinical time allocated to training, supervision and monitoring of checklist usage. We also anticipated that the checklist was going to increase the cost of utilisation of medical items during the course of a surgical intervention. We were a little uncertain as to whether the checklist would actually impact on the length of time spent in the operating theatre, and therefore on the cost of clinical time allocated to the surgical intervention. There was some uncertainty around that prior to actually undertaking the cost effectiveness analysis. But given that the checklist had been found in previous work to be effective at preventing surgical complications, we did expect quite strongly that the checklist would reduce hospital length of stay and therefore the costs of bed occupancy, that there would be some impact on reducing the costs of post-operative care within the hospital, for example, in terms of admissions to high dependency care facilities, and also potentially reductions in healthcare costs after a patient was discharged from hospital. Unfortunately, we could only measure certain items that I've listed here in the table, and a key limitation of this study was that we couldn't measure costs relating to post-operative care within the hospital or healthcare costs after a patient was discharged from hospital. For example, costs in terms of primary care visits or any costs impacts linked to rehabilitative care post-discharge. Just a few words about the actual design of the clinical trial itself. So it was a step-wedged randomized control trial, which basically means that the checklist was implemented in a sequential pattern over the timeline of the project. So what you've got here in this diagram on the vertical is the clusters that were included in the main clinical trial, the five clinical specialties, and along the horizontal, you've got the project timeline, and you can see that the pink, the squares that are filled in represent periods where the checklist was active, and the blank squares represent periods where usual care was active. So, I mean, the way that, in practical terms, the way that a step wedge trial is implemented is that each of the surgical specialties received a numerical code, and then those numerical codes were then subsequently randomly assigned to each of the subsequent were randomly assigned to a date at which point the checklist would become active within each of the surgical specialties. So, for example, you can see that the checklist was introduced the earliest for orthopedic surgery, and at latest for urology. And I think the key advantage of this research design was that it kind of dealt with the practical side of introducing a quality improvement initiative like the WHO checklist within a real world Health Service setting, in the sense that you can only really practically do that sequentially, in a sequential way rather than all at once, if you like. And that this sort of research design kind of nicely aligns with those sort of practical sort of issues around implementing a quality improvement initiative of this nature. This was some of the data that we used for the cost effectiveness analysis, or the sources of data that we used. So we extracted much of the data from hospital patient records, particularly in relation to bed day utilisation, medical items utilised during surgery, time in theatre, and the surgical complications data. We use hospital finance department data to get hourly rates for clinical staff, which we used specifically to cost the clinical time that was invested in some of the core implementation activities around training, supervision and monitoring. We use some external data sources from the United Kingdom that weren't available in Bergen in Norway, specifically around the costing of additional bed days spent in hospital. And we had to make, because this was obviously UK data, we had to make some adjustments to that information so that it became more applicable to a Norwegian context. And we use data from project records and accounts to estimate expenditures that were incurred in implementing the checklist, in identifying core activities around implementing the checklist into the clinical care pathway, and in quantifying some of the time inputs that from clinical staff around training, supervision and monitoring. In terms of cost and outcome definitions and measurement that we adopted for the clinical trial, so our main, our sort of core measure of cost was the total admission cost per patient, which we define as the cost of bed occupancy over the period of hospital admission. To that, we add the cost of medical items utilised during surgery, the cost of clinical time spent in surgery, and then exclusively for the admissions that were exposed to the checklist, we added on the cost of implementing the checklist itself. So effectively, we worked out the total cost of implementation and divided that through by the number of patient admissions that were exposed to the checklist in the trial to get a cost per or an implementation cost per patient. The clinical outcome that we used in the clinical outcome measure that we used in the cost effectiveness analysis was whether or not a hospital admission was free of post-operative complications up to 30 days post-surgery. And this was based on, as I've said previously, a review of clinical case records, and then the application of ICD-10 codes for defining clinical complications, and within a patient's case notes, and then the presence of a clinical complication was then cross-validated with other clinical experts who were brought into the clinical trial to validate the data. So just to briefly summarize the analytical approach that we took in the cost effectiveness analysis. So the key thing to remember here is that we all the data that we used in the cost effectiveness analysis was sampled from a population. So the idea essentially was to generate a plausible distribution of values concerning the difference in total cost, total admission cost, as I defined on the previous slide, and difference in clinical outcome between the trial arms. And we generate that distribution essentially through using something called a non-parametric bootstrap, which in effect involves taking repeated random draws from the clinical trial data, 20,000 times in this case, to generate a series of what we call sample replicates. And then what we essentially did is that we fitted multivariate regression models to each of these sample replicates in order to estimate the differences in total cost and in clinical effect between the trial arms, adjusting for aspects of the trial design itself, and also adjusting for some important preoperative patient characteristics that could have confounded the comparisons that we were making. So we generate this distribution of values, and we use the mean value from that distribution as our best or as our central estimate of the combined difference in cost and clinical effect between the trial arms. And we use the distribution around these mean values as a way of generating some important statistics around the uncertainty relating to sampling error from the clinical trial around the core conclusions that we draw in relation to the cost effectiveness of the checklist. And this is what that analysis produces essentially. This is a scatter plot of the distribution. So on the vertical axis, you have the vertical axis measures the difference in cost between hospital admissions that were exposed to checklist and to usual care. And on the horizontal axis, the difference in complication-free admissions between admissions that were exposed to the checklist or admissions that were exposed to usual care. All the data were expressed per 100 admissions, just to make that clear. And you can see that the dots in the center of the distribution effectively identifies the mean value in terms of differences in cost and differences in clinical effect, which I've summarized there on the right-hand side of the slide. So we estimated that the checklist would result in a roughly a $55,899 saving per 100 admissions, all things accounted for, and that per 100 admissions it would lead to around 6 fewer. It would generate 6 additional complication-free admissions per 100 admissions, and if you look at the distribution on the scatter plot, you can see that, well, essentially around 87% of the distribution is based or is centered around the bottom right-hand quadrant of the scatter plot, and those all the points within that bottom right-hand quadrant represent cost and outcome combinations that are basically saying that the checklist reduces costs and improves or delivers a superior clinical effect. And so from that information, we can basically say that the checklist is that there's an 80% probability that the checklist is a cost-effective alternative to usual practice.
Hi, Andy. Sorry, I need to cut across you here. We've only got a couple more minutes before we have to turn it over to Dr. Sion.
Right. Okay. I'm gonna skip to the lessons learned, to the key challenges and lessons learned. So I think some of the main general practical challenges involved with this study weren't specifically related to the cost effectiveness analysis itself. The main challenges were around the actual clinical trial itself. So the clinical team responsible for implementing the trial needed to get buy-in from all the surgical specialties within the hospitals that were included in the study, and that took some time. And there was also the extraction of data around clinical complications from patient records was quite a complex process and time-consuming process. So I think the key lesson here is that to allow, if you're going to design a study of this nature, is to allow sufficient time for the key groundwork around implementing a clinical trial within this sort of service context, and in relation to this kind of project, and to ensure that it's properly resourced as well. Specific challenges around the cost effectiveness analysis concerned the statistical complexity of the trial design that we needed to allow for in the analysis. So it's important that, I think, key lesson here is to make sure you consult with the trial statistician to make sure that you have these complexities covered in the cost effectiveness analysis. And then I think a key limitation was that we only conducted the cost effectiveness analysis after the clinical trial was finished. And that meant we were kind of having to deal with the hand that we were dealt with, essentially, in terms of the data that we had. So I think the key lesson here is that it's best to design an economic evaluation, a cost effectiveness analysis prospectively, from the point at which the clinical trial is actually designed, so that you have all your bases covered, and that you can be as comprehensive as possible in terms of the data requirements for undertaking the economic evaluation that you want to do. So I'm going to finish there. Sorry, that was a bit hurried at the end, and I hope I haven't eaten into the time allocated for the next presentation too much.
Not horrid at all. Thank you so much, Andy. This was really fascinating. I loved reading your paper. And love this presentation. Especially want to echo, as somebody who likes to do economic analyses, I want to echo that last point that you made, that it's so much easier to do these if they're planned from the outset rather than on the back end. But we will have plenty of time for discussion and for questions for Dr. Healey after the second presentation. Just want to point out that Sarah Nust has once again put the menti.com link in the chat. If you joined late, or if you haven't filled in this link, please do. Just asks you where you're coming from so we can know where our audience is from. And with that, Dr. Sion, over to you.
Sorry about that. It's just a little bit of a technical problem. Guys, thank you all so much for having me. It's a pleasure to be here. I was able to attend your sessions live in person when I was a fellow at the Brigham about 5 years ago, and so it's nice to be back here. So this I'm going to talk a little bit about a little historical perspective here, and give you my background with my involvement in this work. So the timing of this project was really in the early 2000s to 2010, where global health multilateral organizations were changing their emphasis to a degree from a horizontal approach from a vertical approach to a horizontal approach to global health issues. This started in the 90s and really the 2000s with a particular focus on primary care. And there was work done at WHO to include surgery and surgical services into primary care. And so the concept of creating an essential health package was championed and implemented at WHO to say, okay, what services should be offered by various healthcare facilities, and how can we provide comprehensive care to populations that's appropriate to the context and attainable. And there was some desire to look at the intersection of the economics to interventions at healthcare facilities. And, you know, myself and those that I worked with had particular interest in looking at surgery and how surgery was the economics of surgery. And so data was collected for this project in 2008 and in 2009 in the DRC. And I actually was a medical student at the time of this work, and as a fourth-year medical student, and did sort of a summer internship in 2010 in Geneva. And so, sorry, I have a little bit of a cold here. Oops, did that not advance? There we go. Okay, so what was needed at the time was software to be able to dynamically assess costing and resources for planning purposes. And so this IHGP software was created, and it was designed to be sort of a database and repository of items and interventions, and a way for the WHO and interested beneficiaries of health to look at how to provide various services and how to sort of categorize them and how to organize themselves in terms of resources and then obviously costs. And so there was a defined set of interventions that I think scaled up to about maybe 1,000 different interventions, which ranged from surgical interventions to preventative care interventions, really any sort of health intervention needed at a healthcare facility. And depending on the level of healthcare facility, being, healthcare, like a health center versus a district hospital versus a tertiary level hospital for low-income countries, they would sort of scale up or down the interventions. And so each intervention would be comprised of a certain set of procedures, and then those procedures would be comprised of resources. There was highly detailed input data going into this software from human resources to medical devices, pharmaceuticals, and facilities. And where possible, calculations were made to account for the acquisition, deployment, utilization, lifespan, depreciation, capital, and recurrent costs for all of this input data. And so, when looking at this from a development perspective, certain things, could be included, but other things that probably would be there for from a development perspective to bring up certain district hospitals to a certain level. If you're aiming to develop them, certain inputs could not be calculated. So if you're looking to improve a certain center, and the obstacle to improving that center was the lack of paved roads, so that the supply chain got broken, that cost couldn't be added or calculated. Similarly, if more education was needed, that cost couldn't be calculated or added. Also, sort of the assumptions such that a functioning building was present would be made, so that building repairs was not something that would be added. But we were able to include things like ambulance transport to a tertiary facility, for example, in certain interventions that weren't appropriate for a district level. And so these are just some screenshots of how the software looked and some of the inputs And, the level of detail down to pillows and sheets, whether they're disposable or reusable sheets, the time, how much you would weight the use of various things to various interventions. And so, this is how it looked. These are, so conceptually algorithms were made. This is a representation of how the calculations would be done within the software. And so, for example, on the left is HIV and pregnancy. And so these would be, that would be these comprised of these procedures. So you find an HIV pregnant woman and she needs to be dispensed medication, and then she needs to be counseled for 45 minutes. And so each of those things would be a resource, whether pharmaceutical or human resource, and then there would be a time and a cost for each of these things. And this is cesarean section and sort of how that algorithm would look on the right. And so this is a modeling exercise. This was undertaken to try to give some sort of accuracy to how to plan development in various low resource settings. And so this, a country that was interested in this was the DRC. They outlined their health system strengthening strategy in 2006, and that included their standards for what they felt a district hospital should uphold in their country. And so they devised a list of what was felt to be the minimum number of interventions that would be provided, or that should be provided, with certain standards of care. And their goal was to be able to functionally assess the current status of various district hospitals, and then also plan for future resources. So this model hospital was designed to have about between 200 and 300 interventions, inclusive of both surgery and other types of care. The population was set to about 100,000, and a utilization rate was determined by expert opinion. So looking at the hospital registries and utilization of hospital services at numerous well-run hospitals in DRC was sort of averaged and determined to be a utilization rate of 0.15 cases per inhabitant per year, to be an average one to model after. And so again, the goal was really to create something to use in advocacy, negotiation, alignment of funding streams, and field planning. Because in a place like DRC, and obviously many low-income countries, there are numerous entities and players and various funding streams, and how a Ministry of Health is supposed to organize that can be a formidable task. And so this was supposed to, the goal was to make this helpful for a complicated dynamic assessment. And so the pricing for the model hospital came from a variety of resources. A lot of time was spent gathering receipts, invoice lists, purchase lists for pharmacy, salaries from nonprofits, as well as government salaries that were listed. And a lot of time was spent trying to make the actual price of each thing as accurate as possible. So, looking at trying to kind of create an understanding of the context, we also were able to obtain a numerous surveys or situational analysis surveys filled out by various health officers at 12 different district hospitals in the DRC, and we were able to kind of characterize what these different hospitals looked like, and what their capabilities were. And so you can see that most hospitals had, a catchment between 80,000 and 300,000, with beds ranging from 60 to about 300. with 1 to 4 operating rooms, however, intermittent utilities available inclusive of water and electricity. And so we also looked at what interventions, what surgical interventions could be provided at these 12 different hospitals. And it was, and you could kind of see that some hospitals were sort of hit the mark and were high functioning and could offer every essential surgical procedure. And others had challenges and were lacking. And so we ensured that this procedure list was included in the package at the model hospital, and then we did a sub-analysis on 2 of these district hospitals. So when looking at costing of the normative hospital, which again is a model, it was determined that $11.86 per inhabitant per year at a utilization rate of 0.15 cases per inhabitant per year was what all services costed for a particular hospital for a population. And so then when we did a sub-analysis of surgical services in particular, and again, this wasn't created, the IHTP wasn't created for surgery. But we, sub-selected all surgical procedures, inclusive of orthopedic procedures and OBGYN and abscess, IND, things like that, and found that the cost of surgical services was $2.17 per inhabitant per year, which was 18% of the total budget, but that comprised of 33% of the caseload. So, if you're taking up 18% of the budget, but taking care of 33% of the caseload, that the implication is that surgical services are cost effective and would be if you had a good functioning, well-run hospital. And so we then applied IHTP to 2 specific hospitals, the Demba District Hospital and Kabari District Hospital, to look more carefully at how those hospitals were doing and assess them. And so in-depth research was done into their costing, and input data was put into the software to figure out how much surgical services cost. So what we found is stated here at Demba District Hospital. 8 cents per inhabitant per year was the cost of surgical services, which is 24% of the total budget, yet comprised only of 9% of the caseload. And similarly at Kabari Hospital, 69 cents per inhabitant per year was the cost of surgical services, yet that was 20% of the total budget. and that was 3% of the caseload. So, what that means, it's kind of an inverse economy of scales where things this low utilization amplified the cost of resources. What we concluded really was that spending on surgery was remarkably low in these districts, and also utilization of surgical services was remarkably low. And that's what led to this, appearance of inflated cost of surgical services. And so, these pie charts don't relate, but this is to this exact scenario. But the idea was that we could give some sort of structure to the conversations around where to allocate resources. And so this is a slide of someone from WHO, but it shows how conversations can really change. And this was pre and post the pie chart of how the costs can be more data-driven, be data-driven decisions as opposed to, static lists and the difficulties of times past. And so this type of software, I'm not a software, I'm not an economist or a software expert. So I don't want to masquerade as such, but from spending time with this information, and looking at the data with my partners at WHO at that time, there is a large variability in time consumption, in particular with knowledge work. There is non-productive time that's not captured. There were estimates made for a majority of inputs, but over numerous calculations, these estimates can be amplified, which makes you worry about validity. Where overhead should be allocated, I felt is challenging. And then I think overall for this software, it's its practical implementation and utilization it can be pricey for low income countries budgets, and having expertise in how to utilize the software was also a challenge and time consuming. And so this was used probably for a good 5 to 10 years, and it's since transitioned to other things, but I think for a period of time was able to provide some guidance for a good number of countries in their planning, probably about 20 or so. And so that concludes my presentation.
Great. Thank you so much, Dr. Sion. This is super fascinating stuff. Two economic evaluations approaching surgical questions from slightly different angles. Really interesting presentations. We'll open it up right now to questions, and I'm going to take moderator privilege and ask the first to Andy. Dr. Healey, I'm curious, this is maybe a little bit in the weeds, but I'm really curious, your scatter plot results showed, 87% or so of the outcomes were in the Southeast quadrant. So cheaper and more effective, which is everything that any economic analysis wants to find. You do mention that that this was a bootstrapping on a regression analysis on some simulated or resulting in simulated parameter sets. Would you be able to go into a little bit of what sorts of things went into that regression to deliver those parameter sets?
Sure. In terms of the preoperative patient characteristics, it was there was a measure of comorbidity that was extracted from the patient case notes. I can't remember the name of the measure, but it's a widely internationally recognized measure of comorbidity that I'm sure most people on this call would recognize if I could remember the name of it. We included age of the patient, I think gender, and in terms of the adjusting for the trial, the features of the trial design, the regression models also, because it was a step wedge design, we had to control for the timing of the admission as well, in relation to when, in relation to the point at which the checklist was actually introduced. That's kind of a standard thing that you need to do when you're undertaking regression analysis linked to this sort of study design. I'm not sure whether that's answered your question, Mark.
It has. This was again in the weeds, but I was very curious. Maybe we can talk offline. Many of the results are clustered. There are small clusters of outcomes in that scatter plot. But let me turn over. There's a question in the chat, which from Dira. It says, "Amazing talks." It's a question for Dr. Sion. I'm wondering about how to evaluate the current surgical capacity in countries related to the burden of disease, and also how to estimate the ideal capacity. It seems that we couldn't use Western capacity as it is likely too high. And then a second question is the software available for public use?
Thanks, Dira. The question of surgical capacity and how it relates to burden of disease, these are massive questions that are not, that there's not going to be an easy answer, any singular resource. I think that, the global burden of disease study was incredible, and playing with those tree map charts, I think at University of Washington, is a fun exercise to do, to try to understand and sort of comprehend the complexities of the question of burden of disease, and also the limitations of modeling. because you could probably ascertain some, just playing around with that particular model or representation, you can see where there might be some, it might not represent the reality of burden of disease in all circumstances if you spend time with it. So how it relates to current surgical capacity, how do we assess it? I think that the situational analysis tool, while rudimentary and snapshot, I do think was very useful for a period of time, sort of showing quickly what can be done at different facilities. I know that there have been different iterations of a similar snapshot tool, but that is, I wish I had a good answer for you, but how to evaluate current surgical capacity is it's a very technical question that I think requires a lot of work to fully understand. I agree with you that it is difficult to apply sort of a Western standard. You could say, okay, well, if we have this much appendicitis in the US, shouldn't we have this much appendicitis in a low-income country? Well, sure, but as it sort of as that scales up to more organ systems and more diseases and more issues, it becomes much more complicated because we have so much more screening, so much more primary care, so much more people are presenting so much more, and so it's hard to exactly relate because it's an entire system of issues, not just a singular. It's an easy singular concept, but when applied to reality, it's very complicated. And so the IHGP software, it is available. It is free, so to speak. It's at the WHO. I can put you in touch with the people. I was conversing with them last week that sort of have the institutional memory of it. But I think that the barriers to its implementation are what I said at the end, in that you need someone with, the expertise in the software, which isn't hard, but the amount of work that goes into getting all the input data in contexts where being fully transparent about finances can be a little bit tricky because there are so many different funding streams and different power structures, and it just can become a tricky sort of thing to play with. But it is, if there is someone or an entity with like sincere, deep interest, it is available. Sorry, it's kind of a roundabout answer.
Thank you. Just to say, there are two ways to ask questions. You can type them into the chat and I'll read them out to the presenters, or as you can see, also you can raise your hand. Either one works. But let me do another question in the chat from Megan Lim to Dr. Healey. The cost effectiveness of the surgical checklist may vary depending on the type of healthcare system, but public versus private. Would you perform the analysis any differently depending on the type of healthcare system?
Thank you for that question. I mean, the thing, it's a good question, because when you look at evidence of the type that we generated in Norway, you have to be very careful about how you interpret it in the context of other geographical locations, other healthcare systems, because the impacts might not necessarily transfer from one place to the other. In direct answer to your question, Megan, I don't think the methodology would change necessarily in terms of you'd still do a cost effectiveness analysis as I defined it in the presentation, and you'd still apply the same sorts of statistical methods and all the rest of it. Where you might differ is in the scope of, this is ideally, if you were designing the study from the start, you might think differently about the scope of measurement in terms of resource impacts, for example, because obviously different healthcare systems, they interact with different different parts of the wider system differently, depending on the type of healthcare system that it is. And it's important in an economic evaluation also to be clear about from whose perspective you're doing the evaluation from. So yeah, I mean that. Yeah, so it could. The short answer is yeah. It could. Not in terms of the methods, but in terms of the scope and the perspective of the study. I think that would differ. I hope that's a satisfactory answer.
Yeah, thank you, Andy. It is clear that one shouldn't take the results of your study, which was really well done, and then say, as a result, the surgical checklist is a cost-effective measure. Full stop. It's a cost-effective measure within the context in which the study was performed, but that may not be true in, I don't know, Senegal or the US even, or anything like that. Dr. Head, over to you.
Thanks. Actually, my question was very similar to Megan's, and would love to continue to push on that point. So this week we had our journal club, and we talked a lot about how these very local studies might inform decisions that we make. And so, this is in a very particular context in Norway, or in very specific settings in different countries in sub-Saharan Africa. And so how do we think about like the costing study that Dr. Sion did, and think about, is it applicable to other settings, or what is the lesson learned there? And so, for both of you, you did push us a bit to think about and other settings besides, or to expand out how we think about where this might be applicable. But I'd love to hear more about your thoughts about what you did within your own work to make it more generalizable to other settings, or what we would need to be able to take conclusions that you make in your papers to drive decisions that we make in other countries. Or is it truly just very local to your settings and to the context that you're working in?
You want me to go first, or is Melanie?
Go for it. Yeah, go for it, Andy, and then we'll go over to Melanie.
Yeah, I mean, I think it's a fact of life that when you're talking about translation of evidence into practice, you're talking about evidence that was generated in context that won't relate to where the thing it is that you want to put into practice is being implemented. So you're always going to be faced with the issue that the questioner has just raised. I mean, the way that economists tend to approach this is that when they're trying to make more general statements about whether something is a good thing, more generally, they would undertake modelling. And the modelling would be based on a synthesis of the evidence from clinical trials or epidemiological studies that were undertaken across different contexts. But I think that there is a need to recognise that because you're making that translation from one place to another, there will always be a degree of uncertainty as to whether the impacts that you've measured in one place will be translatable to another. And I guess the best way of doing that would be through things like sensitivity analysis, for example, and to make these uncertainties transparent and to explore them and to explore their impact on your conclusions. So that would be my response to the last question. I don't know if Melanie wants to add to that.
Yeah, well, I think that this software, it was designed for, even though it's supposedly for any setting, I think that it's most applicable to low-income countries, the IHGB software. And I think, like with any modeling, having contextual awareness of is important, especially when looking at results and interpreting results. And modeling is meant to be dynamic so that it can change and grow and evolve based on new information or changing information. So, how do we get to the best answer for anything? Modeling is a great way to get there. And so I think this particular software, like I said, I'm not its spokesperson. I did an internship and worked with it for a period of time, but I do think it was done well and thoughtfully, and could be and was widely applied to numerous countries. I think that just the barriers to its use and implementation are why it kind of petered out.
Any modeler will know the quote from Ernest Bach's, all models are wrong, but some are useful. So yeah, let me move on. There's a question in the chat, but let me move on to Alex. You have your hand up.
Hi, thank you, Dr. Sion and Dr. Healey, for such interesting presentations. My question is for Dr. Healey. I'm working with an organization called Lifebox Foundation that implements quality improvement programs to make surgery safer, and a big component in our programs are incorporating the surgical checklists in many of our middle income countries. And one of the barriers that we've also faced is, you had mentioned, getting people's buy-in, in your case, the step-by cluster trial. And in some of the countries we faced where providers, it's been difficult to get their buy-in to even use the checklist at all. And so I had two questions. One was, what do you think are some solutions when you face these challenges in behavioral changes, whether it's participating in a trial or whether the providers think that the checklist is useful or not at all? What are some solutions you think you can use to address these particular challenges with buy-in and getting the providers cooperation as far as the project or the program? And then number two, what do you think are some costs that can be reduced with actually implementing the checklist? I'd imagine that a lot of the costs come from the trainers and then people in the research team who are actually delivering the checklist. But do you think that there are other costs that can be reduced in the actual implementation? Thank you.
Well, I mean, in answer to your second question, I mean, the checklist is a low-cost activity in itself, but its impacts can be quite far-reaching in terms of some of the obvious items, and they would be impacts on things like hospital length of stay. I mean, any healthcare system. I mean, in the UK, for example, we have a big issue about bed blockage and people staying in hospital for too long and blocking beds for people who need to come into hospital at the other end of the system. So I think that's one of the major benefits of the checklist. I would think, and I would imagine that would translate to resource to low-income country settings as well, where bed availability is a particularly scarce resource, I'd imagine, in the secondary care sector. Your first question is more about getting buy-in. I have to be honest with you. I mean, I came into the project quite late. We did the economic evaluation after the clinical trial finished. So it was the clinicians who led on the trial that did all the hard work around getting buy-in from the surgical specialties in Norway, investing time in doing workshops with them and all that sort of thing. So I don't really have any magic solutions on that score. I wish the clinical lead could have been with me on this call, and he might have been able to give you some feedback. I could put you in touch with him if you like, if you want some practical solutions to what you're doing, where you're working, and maybe he can offer you some advice if that would help. But I wasn't involved in that part of it, so it's a bit difficult for me to. I'd be speculating a lot if I started offering you advice about that. But it took a lot of time and effort. That's what I can say, because that's what he fed back to me.
Yeah, sounds good. Thank you. I'm happy to connect with you offline as well. Thanks. I appreciate that.
Thanks, Alex. Dr. Healey, you're getting the brunt of the questions here. The next question in the chat says the cost effectiveness analysis was limited to a single hospital site and 3 surgical specialties. This may be a bit of speculation. Then what might be the implications for a multi-hospital and multi-specialty evaluation? In your opinion, how does this generalize to include low and middle income countries? And are the results still valid given that the original study was done a while ago?
In terms of the last of those set of questions, are the results still valid? Well, I've no reason to think not. I mean, the question, the other group of questions kind of speak to the earlier question that we had about whether we can translate evidence from this study to other contexts. I mean, one of the big disadvantages of our study in Norway, for example, is that we didn't include general surgery, which I believe is the high volume surgical specialty. If that's, I'm sorry if I'm talking nonsense here, but I think that was one of the key concerns that we had. Whether what we found in relation to those specialties that we did include, whether that would translate to other specialties and to other settings, I don't know. But I don't have a quick answer to that. But if you wanted to use the evidence that we did generate and apply that to other settings, then I would take the approach that I suggested in response to the earlier question, which would be to think about, you know, being open about this uncertainty and doing sort of sensitivity analysis to look at what impact it could have on your conclusions.
Thank you. The PGSSC does a journal club on these papers before this, and Dr. Hetgauthier has put in a question that came up in the journal club, which is for you, Dr. Sion. Thinking about other limiting factors, if the funds that were necessary that you identified could actually be raised, what are other barriers that you might have identified beyond simply funds?
You mean funds to implement this software and utilize it by various ministries of health, I'm assuming. So the other barriers, I think the biggest one, because, you know, even I was inspired to try to utilize it at a site at one point in discussion with the hospital administration there. And there are a lot of people that don't want to be, for various reasons, fully transparent. It's not easy to allow external sources, especially with the power differential dynamics, people to come in and look at all your books and go through all your receipts and, you know, nitpick through every little expense. People, it makes people uncomfortable. So getting, understandably so. So I think that probably in reality would be the biggest hurdle. And then I think having people with the technical expertise to, which is not impossible, but educate and put people in positions to input the data accurately is possible. It would just take time. You need full-time people to do that. So those are really, those would be, I think, the biggest challenges, but it is usable, and they're, you know, the people that created WHO, I mean, they never wanted it to kind of dissipate. It just did for practical reasons, because of practical things.
Awesome, thank you. I know some folks have to get off about 5 minutes early, so Marta Lord, I'm gonna actually give you the last question.
Okay, thank you very much. Thanks, Dr. Sion, Dr. Healey for the presentations, and Matilodi Fanichi about the Global Surgery Policy Unit of the London School of Economics. I'll just quickly go to my question quickly. Dr. Sion, I've seen two papers, at least in recent times, that have looked at the relationship between what we measure in institutional analysis, the infrastructure and personnel and equipment and all that, and outcomes, or volumes, services provided. And the two studies actually have something in common in their findings. There's actually little or no correlation between capacity indices as we measure them currently and volumes or output from the hospitals. I was wondering from your experience whether you think there are better ways of measuring the capacity, or whether there are ways to improve how we assess surgical capacity of hospitals from what we are doing currently. Thank you.
So assessing capacity, so surgical capacity, I can't say I know numerous contexts in low-income countries, but from what I've observed, I've worked in depth in Malawi, Africa, and from what I've observed, the health information management system that is funded by multilateral organizations is what gets the most in-depth data about what is being done at hospitals and hospital systems. And so my understanding is that surgical metrics historically haven't been collected in these large databases. And so I think that with the addition of the surgical metrics to the World Bank, I think that the surgical metrics are going to start to be included in large national and international databases more and more because of those metrics that everyone at Harvard played such an integral role in. So I don't think there's an easy answer for that question, like in an immediate sense, but I think over the course of time, there's going to be more and more large data gathering about surgical services, and therefore we'll be able to ascertain capacity from that. And I think it's going to take place over the next 5 to 10 years.
Thank you, Dr. Sion. Thank you, Marshall, for that question. Thank you, Dr. Healey, as well, both of you, for your presentations and for your answers to these questions. Perfect. I was about to ask Megan if she would share the last slide. So here is a map of where everyone was calling in from. So quite a broad distribution of attendees. My favorite is the person in Antarctica. And then Megan, if you could go on to the next slide. Great. So our next research seminar will be on March 9th. So keep an eye out on your emails, Twitter, etc., for announcements about that. And once again, thank you to Dr. Healey and to Dr. Sion for today.